Hello, my name is Dr. Ukiri Richard. I'm continuing this podcast on basic cardiology. Today we are going to talk about recurrent thorax pain. Our case today is of a 61-year-old patient who has been having recurrent chest pain for 3 days and was delivered to your chest pain unit through the emergency medical care. There is no past cardiac history of note, and apart from nicotine abuse and a non-medically treated hyperlipoproteinemia, also arterial hypertension, there is no cardiologic risk factors, and physical examination was not pathologic. My question is now, I would like you to give a broad differential diagnosis of recurrent chest pain. So let me start with the cardiovascular diseases that cause recurrent chest pain. You could have coronary heart disease. You could have myocarditis, pericarditis, or combined perimyocarditis. You can have acute aortic syndrome, which is either aortic dissection or aortic aneurysm, hypertrophic obstructive cardiomyopathy, aortic stenosis, hypertensive heart disease, and tachycardia health rhythm disturbances. For the pulmonary causes, it could be pleuritis from pneumonia or pneumothorax, could be pulmonary embolism. From the musculoskeletal system, you have cervical or thoracic vertebral syndrome, rib fracture, rib swelling and intercostal neuralgia, Tietze syndrome, morbus zoster, myopathy, and metastasis. For the gastrointestinal causes, you could have reflux esophagitis or esophageal rupture, esophageal spasms, achalasia, gastritis, ulcers, acute pancreatitis, gallstones, or Romheld syndrome. Now, mediastinal diseases, you could have space-occupying lesions in the mediastinum or mediastinitis. For functional heart complaints, it could be panic disorders, hyperventilation syndrome, or what the Germans call Rente-Begehren. So, what are the primary diagnosis steps you will take? Well, laboratory, you will check for the full blood count, glucose, sodium, potassium, CK, GOT, LDH, troponin, CRP, creatinine, urea, PTT, TP, thyroid stimulating hormone, and D-dimer. You will also do ECG. Okay. In the laboratory test, you had elevated troponin from 0.017, that is about 17 times the normal limit, while the other laboratory parameters were okay. In the ECG, the reading was sinus rhythm 79 per minute, left axis. You could see pre-terminal negative T waves in V2 to V5. The other findings were morphologically okay. So, what is your diagnosis? Well, it's very clear here. The diagnosis is non-ST elevation myocardial infarction, abbreviated as NSTEMI. What are the primary recommended therapeutic measures to be taken? For this case, oxygen should be given through the nose or through mask. ECG monitoring is mandatory. If the blood pressure is above 90 to 100 millimeters of mercury systolic, you give symptomatic nitroglycerin 0.4 to 0.8 milligrams sublingual. If the symptom persists, you give an infusion of 1 to 6 milligrams per hour. If despite the administration of nitroglycerin, the patient still remains with the above symptoms, you can give, after a pre-medication of 10 milligram metoclopramide, 3 to 5 milligram morphine intravenously until the patient becomes symptom-free. Additionally, you can give aspirin either as chewable tablet, one 160 to 25 milligram, or intravenously 250 to 50 milligram. Additionally, though it is not in the guidelines, you could give a loading dose of 300 to 600 milligram clopidogrel, alternatively 60 milligram prasugrel, if there are no contraindications. Beta blockers can be given if there is tachycardia or elevated blood pressure, especially when there are no signs of heart insufficiency. You could initiate an anticoagulation, which is actually dependent on your plan for further treatment, whether invasive or non-invasive, and bleeding risk. Let me run down the choices of available anticoagulation. Unfractionated heparin could be given intravenously 60 to 70 international units per kilogram to a maximum of 5,000 international units. Thereafter, an infusion of 12 to 15 international units per kilogram per hour, which runs at a maximum of 1,000 international units per hour, titrated according to PTT with an aim of 1.5 to 2.5, the normal limit. Alternatively, enoxaparin, which is clexane, can be given subcutaneously 1 milligram per kilogram twice daily. Other available anticoagulations are fondaparinux, 2.5 milligram per day, dalteparin, 120 international units per kilogram twice daily, nadruparin, 86 international units per kilogram twice daily, subcutaneously. For our above patient, he was given aspirin intravenously and 600 milligram clopidogrel. But because of the ECD changes and the clinical presentation, and because the patient is still not free from his symptoms, he was given an additional 5,000 international units of unfractionated heparin. And a coronary angiography will be planned. Okay, just as a side tracker, the students close to you asked you a sensitive question. Why are you not considering the administration of glycoprotein 2B or 3A receptor antagonists in this patient? Until recently, patients with high risk, especially with elevated troponin, diabetes mellitus, or ST segment depression, we are given routinely tirofiban or mtfibatide as initial therapy, in addition to oral thrombocyte aggregation inhibitors. But now these have class 3B indication and should not be given. Only in cases where you have evidence of significant thrombus load through angiographic studies, that is when you give 2B/3A receptor antagonist, and preferably is abiximab, which has a class 1B indication. Now again, the students ask another question. When is the right time for the invasive intervention or the invasive diagnosis? For high-risk patients, the use of an immediate is less than 2 hours invasive diagnostic through a heart cardiac catheterization has been proven to have a 1C recommendation. For patients with elevated troponin, where after application of basic medications, they become symptom-free, rhythm and hemodynamic status are stable, it is okay. It is a class 1 indication when you do the coronary angiography within 72 hours. A routine coronary angiography by a patient with low risk is not advisable. It has a class 3C indication. The next question is, what do you mean by high-risk patients? So, a coronary angiography was done on this patient, and he was found to have diffuse coronary sclerosis, a subtotal stenosis in LAD, in the middle part of LAD, and a direct stent implantation was given to this patient. The LAD is the left main coronary branch. So my question is now, how do you decide whether to give a medicated drug-eluting stent or non-medicated bimetal stents. Well, the decision to use either of both stents shall be made based on the risk and usefulness, also with the comorbidity and eventually the necessity of a non-cardiac operation that may need the stopping of the thrombocyte aggregation inhibitor, which has a class 1C indication. It should be noted that in the treatment of NSTEMI or STEMI, the only difference is the time, the time interval to the invasive measures. It should also be noted that lysis therapy is usually contraindicated in NSTEMI.